Good afternoon, everyone. Let's go ahead and begin our webinar. Welcome to the webinar today on racial and ethnic disparities in dementia, facilitated by the National Alzheimer's and Dementia Resource Center, which consists of our team at RTI International. I'm Sari Schumann with the Resource Center team, and I will be moderating our webinar this afternoon. The purpose of these webinars is to provide helpful, current, and applicable information for AD-SSP and ADI-SSS grant projects and others in the Aging Network. Please note the webinar today is being recorded and the PowerPoint presentations will be sent to all of you soon after the webinar. We will allow time for questions through the webinar's chat feature at the conclusion of the presentations. If you have a question during or after the presentations, please enter those into the chat feature of the webinar. At this time, I'd like to turn it over to Erin Long from the Administration on Aging, Administration for Community Living, to provide a brief welcome.
Hi, everyone. Thank you very much for taking the time out today to join us for our webinar on this very important topic. I would like to thank our presenters, Lisa Lines and Constantina Mizis, for their sharing the information that they have on the issues at hand. I look forward to a great dialogue at the end in the question and answer session. And if you have any feedback on the webinar that you would like to provide, please do feel free to communicate that with me. My contact information will be provided at the in the references box. With that, I will turn it back to Sari to get going. Thank you.
Thanks, Erin. Today we'll hear from Lisa Lines and Constantina Mizis about racial and ethnic disparities in dementia. Lisa Lines is a health services researcher at RTI International and an instructor in quantitative health sciences at the University of Massachusetts Medical School. She is the author or co-author of articles and reports on a number of healthcare-related issues such as racial and ethnic disparities and inequities, patient-centered medical homes, care coordination, and person-centered care. She has been featured as an expert on racial and ethnic disparities on public radio and at national and international conferences. Dr. Lyons is currently involved in studies of cancer care quality, care coordination for people with chronic kidney disease, primary care reform, and patient-centered medical homes. Constantina Mizis is the founding executive director of the Latino Alzheimer's and Memory Disorders Alliance, known as LAMDA, which is based in Chicago, Illinois. LAMDA is on the front line of addressing the growing impact of Alzheimer's disease on the Latino community and provides direct services to thousands of Latinos struggling with Alzheimer's disease annually. Mrs. Mizis has dedicated over 20 years of service to Latino older adults and their family caregivers, consulted and trained extensively throughout the United States, and worked with national organizations on the development of programs for Latino elderly. NPR, the Chicago Tribune, Univision, and NBC are some of the media outlets that have highlighted her work. We welcome and thank them for their presentations today. First, I will turn it over to Lisa.
Good afternoon, and I would like to first thank Sari and the rest of the Resource Center team for inviting me to present to you all today. And I'd also like to acknowledge that much of the content for this webinar was developed for a literature review that was published last year. It was co-authored by Noha Sharif and Josh Weiner, sponsored by the U.S. Department of Health and Human Services Assistant Secretary for Planning and Evaluation. So today's presentation will be talking about disparities, differences and disparities among racial and ethnic subgroups among people with Alzheimer's disease and related dementias. We'll talk about these disparities and differences in terms of risks of having the disease, chances of being diagnosed, issues around informal caregivers and use of formal services, and then some of the hypothesized reasons for these differences and disparities. So why is this issue important? Why is this important today? What is the importance of diversity among people with dementia? Well, the U.S. is becoming more diverse, and there are significant differences and disparities in a lot of different aspects of dementia across racial and ethnic groups. So as the U.S. becomes more diverse, this will become a growing issue. From 2010 to 2050, the U.S. minority population over age 85 is projected to increase quite a bit. African Americans will increase from 7% of this population, the over 85 population, where dementia is most common, to 10%. Hispanics, the proportion of the population over age 85 that's Hispanic will triple, and the proportion that is Asian will quadruple by 2050. So this is a serious concern because of these differences and disparities in dementia and Alzheimer's. So what do we mean when we talk about disparities? There are lots of different definitions of disparities. For framing our review, we basically stuck with the Institute of Medicine's definition, which comes from their report from 2003 called Unequal Treatment. And they define disparities as differences in the quality of healthcare that are not due to access-related factors or clinical needs, preferences, and appropriateness of interventions. Now, one of the issues about this definition is that access-related factors, clinical needs, preferences, and appropriateness of interventions all can vary a lot, both among and between racial and ethnic groups. And access-related factors and clinical needs are often greater in people from lower SES backgrounds. So the Healthy People 2010 report and the ARC National Healthcare Disparities reports use different definitions. They say, in pursuit of the overarching goal of eliminating health disparities, all differences among populations in measures of health and healthcare are considered evidence of disparities. So keep that in mind as we go through this, that there are definitely differences in how disparities are defined. If we stick with this discussion of disparities and differences and looking at the IOM definition, we can think about measuring quality of care on a continuum where you might stratify by race and ethnicity and see differences and then disparities that the IOM would say are focused on these areas of healthcare systems, legal and regulatory systems, and then discrimination and bias. So as we look at differences and disparities in Alzheimer's disease and related dementias, which we'll abbreviate for convenience, there's a higher prevalence of ADRD among African Americans and Hispanics, and that's shown in multiple studies. The most common estimates that we see in the literature, it's about twice as common among African Americans and 1.5 times more common among Hispanics. But that doesn't account for the fact that it's an underdiagnosed disease in general, and this issue of underdiagnosis is more pronounced in minorities, and that's shown in multiple studies. For example, one study using data from the Health and Retirement Study, which was a cohort of, it is an ongoing study, a cohort of people aged 55 and older. All of these people had been independently confirmed as having cognitive impairment. 46% of whites had been told by a doctor that they had cognitive impairment. Now remember, all of them had it. 46% of whites had been told by a doctor that they had it, but only 33% of African Americans and 34% of Hispanics had been told by a doctor or reported that they'd been told by a doctor that they had cognitive impairment. So this is a big issue. African Americans, Asians, Hispanics, and other minorities are severely underrepresented in clinical trials. And that may be because of clinical factors like having complications that might disqualify a person from participating in a clinical trial. It could be due to language barriers. A lot of studies require proficiency in English. It may also have a lot to do with a lack of trust in some communities around medical research. And some of you may be familiar with the legacy of the Tuskegee syphilis study. That and other sorts of historical mistreatment has certainly led to a lack of trust in some communities. So that can be a problem in terms of clinical trials, people not being able to be recruited, having a less diverse clinical trial population can lead to a lot of problems in knowing what interventions will work best in what communities. We also know from one study on African Americans that they self-report more impairment and disease burden than whites. Again, that's limited information, but we do have some information on that. And we also have some limited information around age at onset and impairment at diagnosis among Latinos. More information is definitely needed about how these things vary among racial and ethnic populations. Some other differences that we've seen in the literature have to do with use of formal supports, such as nursing homes. And this chart that I'm showing you here was adapted from one study that looked at the proportion of African Americans, whites, Hispanics, and Asians in nursing homes in 1999 and 2008. So these are rates per 1,000 persons over 65. And you can see that African Americans are more common, more likely than other races to be in nursing homes. And from other research, we know that African Americans are more likely to be in lower quality facilities than whites. Hispanics and Asians are more likely to use family caregivers, and that has its own issues. We know from the research that older African Americans and Hispanics with dementia have significantly higher costs than white patients with dementia. They are less likely to use hospice than whites, more likely to use home health, tend to have more inpatient admissions and longer lengths of stay, and more physician visits. So what are some of the underlying reasons that we see these disparities? This is sort of a summary of the five sort of main, 5.5 sort of main reasons that we would see in the literature. Measurement issues, cultural factors, genetics, behavioral factors, barriers to access, and sort of arching over all of those is unequal treatment. I'm going to talk about that some more a little bit later on. But before I get there, I want to talk about the complexity of this issue. The figure that I've got up on the screen now is adapted from an article by Glymer and Manley, and it talks about the life course patterns of these diseases, dementia, cognitive impairment, Alzheimer's, and how complex the mediators can be. We start, we look at race and ethnicity as a factor, and then we think about all of the different things that go along with that: geographic exposure, immigration, socioeconomic status, discrimination, group resources, ties, and identity. And those feed into the individual level mediators, things like material conditions and psychological stressors, cognitive engagement and test-taking skills. All of these are related also to proximal mediators, such as physical health and health behaviors, access to medical care. And then these feed into cognitive function, impairment, and change, and that all leads to the diagnosis of cognitive impairment. On the next slide, we sort of think about this in a slightly more simplified way. We think about in statistically adjusting for something like education. What you see here is sort of just a very simple diagram of the relationships between, pre-existing SES, socioeconomic, and cognitive advantages that lead to more schooling, and both of those things can be protection against cognitive aging. So when we do statistical adjustments for things like education, SES, and health status, a number of different things can happen. So some measurement issues, I don't want to spend too terribly much time on this, but it is something that people should be aware of as they look at the literature and think about disparities among racial and ethnic populations. For blacks and whites, if you adjust for health status, it reduces African Americans' apparent health care use and thus increases disparities. If you balance Hispanics and whites on SES, you greatly increase Hispanic healthcare utilization, and you shrink his disparities. So decisions that researchers make when they're doing statistical adjustments can certainly affect what we see as far as disparities. We also have the issues of differential item functioning. That is a term for what happens when people of different backgrounds, races, ethnicities, whatever, react differently or have different responses on items on surveys or assessment instruments. And I give here the example of the Boston naming test because I think it's a particularly instructive example. This is an instrument that's still in use today, and it's an instrument that's given to people to diagnose dementia. And one of the items that's shown to respondents is a hangman's noose. And certainly that would have very different implications for elderly African Americans than for whites. So when we have that kind of thing happening, it certainly can make a difference in terms of what we see in terms of disparities. Cultural factors are also very important. Different races and ethnicities have different concepts of caregiving and familism, and different models of aging, and different levels of stigma around someone having cognitive impairment. And next, let's talk a little bit about genetics. So genetic risk for Alzheimer's disease is not is very complicated because race and ethnicity are cultural and social concepts. They're not biological concepts. So when we look at genetic studies for a risk of Alzheimer's, we see different results in different populations. We see that, for example, one allele, the E4 allele, is associated with higher risk among African Americans in Indianapolis, but not among the Yoruba people in Nigeria. And this just is an illustration of the diversity within racial and ethnic subpopulations and how, why we see such a variety of results in the literature around genetic risk for Alzheimer's disease. Another big issue in terms of explaining disparities between or differences between racial and ethnic groups is differences in baseline levels of cardiovascular disease and other risk factors for dementia. All of the conditions that are listed there or behaviors that are listed there are more common among certainly among African Americans and Hispanics. And so that can be another possible explanation for differences that we see between subpopulations. And then when we think about barriers to access and quality, I mean, this is a very complex set of influences as well. Poverty, language, lack of familiarity with the healthcare system, lack of health literacy, poor communication with providers, mistrust of the healthcare system, lack of education, and lack of adequate health insurance can all be barriers to access and quality. And overarching all of that is the issue of unequal treatment. So we, as providers, certainly have a role to play in reducing barriers. And that's where I'd like to talk a bit about evolving frameworks for addressing disparities. And so as we started with this definition from the Institute of Medicine from 2003, looking at the definition of disparities as things that are not due to access-related factors. But more recently, we have seen, more recently we've seen a different evolving definition of how to everyone. So the most recent National Stakeholder Strategy for Achieving Health Equity report from the U.S. Department of Health and Human Services in 2011 came up with this quote, which is that health equity is attainment of the highest level of health for all people. Achieving health equity requires valuing everyone equally with focused and ongoing societal efforts to address avoidable inequalities, historical and contemporary injustices, and the elimination of health and healthcare disparities. So the National Strategy for Achieving Health Equity focuses on 5 goals. The first goal is awareness, and that's where we are at today, where we're increasing the awareness of the importance of this issue and how importance may grow over time as well. We are also focusing on leadership because all of you on the call are leaders. So we're strengthening and broadening the leadership support for addressing health disparities. And then goal 3 is the health system and life experience goal, improving outcomes across the life course. Goal 4 is competency, cultural and linguistic competency. And goal 5 is data research and evaluation. And all of these are important as we address disparities, because diversity in the U.S. is here to stay. And if we are to meet the needs of our entire population and provide high-quality care to everyone, we must take a person-centered approach above everything else. Culture is group level, and groups vary widely. And so social determinants can be modified, but we must take away unequal treatment first. Implicit bias can be highlighted and brought to consciousness, and awareness is the first step. Cultural competency programs can be very helpful in correcting those problems in unequal treatment. And quality improvement can improve quality for all, but targeting programs to areas of the biggest quality gaps can result in the biggest gains. And I will leave you here with the references for more information. The first reference is the review article that I mentioned at the beginning of the presentation, and that has a lot of the background studies and details on what the literature has to say about disparities. And thank you very much for your attention.
Thank you, Lisa, for that great presentation full of lots of helpful information. We're going to move on to Constantina Mizis' presentation now. And after she concludes, so I will turn it over to Constantina.
Hi, Sari. Thank you so much. I would like to thank Sari and the Research Center team also for their support and inviting me. Well, it's following what Lisa told us. Obviously, we need to respond to the community. And this is what I'm going to talk about it. According to the U.S. Census Bureau population estimates of July 2013, there are roughly 54 million Hispanic living in the United States, representing approximately 17% of the U.S. total population, making people of Hispanic originations larger ethnic or race minority. Most of them are Mexicans. We are talking about the 64%. And then we have Puerto Ricans, 9.4, and the rest are Central Americans. Dementia in Latinos. The prevalence of dementia in Latinos older than 85 years is elevated more than 40% compared to non-Latinos. Alzheimer's disease represents the 60% of dementia identified in the Latino community. Alzheimer's 2013 report is the 8th leading cause of death of Hispanic or Latinos. The risk factors, very similar to the African American population. The Latino community has a variety of known risk factors of Alzheimer's disease and cultural barriers that prevent them to getting the treatment they need. And this includes an aging population, the high rates of chronic disease such as diabetes, obesity, and heart disease, the lower factor of education, and income levels. On aging population, age is the number one risk factor of developing Alzheimer's disease between 2008 and 2030. Will be a really impact. The Latino population age 65 years old and older will increase by 124% compared to 64% increase for the non-Hispanic white population. The high risk of chronic disease is another factor, such as diabetes, obesity, and heart disease among Latinos. Research indicates that there is a strong correlation between individuals who show signs of prediabetes and those that develop Alzheimer's disease. Since Latinos also tend to have lower rates of health insurance and receive less medical care than non-Hispanics, they are less likely to get care for health problems that might lead to Alzheimer's disease. Lower education and income levels among Latinos limits their access to different healthcare options, including access to health insurance. Difference in educational attainment remain among racial and ethnic groups, with older non-Hispanics whites more likely to graduate from high school than older Hispanics. We are talking about the 84% versus 54%, and I want to highlight that this is one of our huge barrier is the low factor of education. When we have, for example, health literacy in Spanish, when we have brochures in Spanish, flyers in Spanish, books in Spanish, it is unfortunately not enough because they don't have the knowledge to read some vocabulary or a specific vocabulary due to the low factor of education and number of years that they attend to the school. So we cannot assume that because we provide in a material there is in Spanish, they will understand that material and just avoid to assume that they will understand or get informed even. The median personal income for Hispanics 65 years and older for men was $15,240, and for women $11,255. And this is information from the U.S. Census Bureau. Hispanic caregivers in the United States. And when we are talking about caregivers, we have to specify who they are. And the Hispanic community, the caregivers are the family relatives. And the Hispanic community assume that when their parents, get old, the children must take care of them. And that's why we saw in Lisa's presentation that this community don't go to nursing homes like other communities in numbers and high numbers, or actually the Hispanic community do not know most of the time what hospice means because, well, that's another story. The word hospice in Spanish has another meaning. It's not the meaning that we have here in the United States. So 1/3 of the Hispanics household report having at least one family caregiver. This is a 36% for a chronically ill or elderly family member, with an average of 1.83 caregivers per household. There are an estimate of 8 million Hispanic caregivers in the United States. Diabetes is the top reason with Hispanic caregivers say their recipients need care, and it is almost twice as prevalent a reason for them as it is for non-Hispanics. We're talking about the 15% versus the 8%. Cancer is the next one. Old age and arthritis are the most common, 7% each one. Also, Alzheimer or mental confusion is cited by only the 6% of the Hispanic caregivers as the primary reason for their care recipient needs care. A total of 23% say their loved one does suffer from Alzheimer's disease or dementia. ,84% of Hispanic caregivers believe that their role is an expectation within their upbringing. 70% think that it will bring shame on their family, and this is part of a cultural issue. not to accept their caregiving role. They assume they will be caregivers in some point of their life. Caregiving is a shared responsibility. 82% say that they get some help from a relative or friend. And what we have in the Latino Alzheimer's Alliance very frequently are individuals who are suffering from dementia, and what they live actually in different houses during a week, 1 or 2 days with one child and the other 2 days with another child, etc. So that they frequently move. Hispanic caregivers are family relatives, often with lack of knowledge on healthy practices and healthcare resources. This is something that we see every day. So what we do in our community response to this problem has been the implementation of the program Health Promoters Against Alzheimer, what we call HPAA, that trains community members on becoming care advocates, in other words, or health promoters, promotoras de salud, who can access and educate the community on health literacy and practices. And this is what I was talking about on regards that is not only translated material, but also we need the care advocates, and they need to be bicultural. The health promoter's role is, number one, conduct outreach and community education activities to identify families needing services. Number two, arrange for in-home respite care. Number three, assess, educate, support, and connect families to community services. Number four, provide a cultural and linguistic bridge that connects families to services. And number five, serve as a dementia resource consultant to other staff in the partnered agencies. The results. With the Health Promoters Against Alzheimer program, we educate the community on Alzheimer and other dementias, as well as type of services available to the families. And I want to highlight here that when we said Alzheimer and other dementia, it's because the Latino community, they don't see the difference between, or they do not understand the difference between Alzheimer and dementia, and they get really confused on regards. LAMDA, Latino Alzheimer's Alliance, has to date reached out to over 4,500 Latinos in more than 20 communities through face-to-face programming through this HPAA program in New York, California, Illinois, Maryland, and Florida. More results in 2011, prior to a HPAA program, most participants, 84.6% reported never having attended informational programs that dealt with Alzheimer's or any other mental health topic. A great majority, 88.7%, has never spoken with a health professional about Alzheimer's disease. Following program implementations, participants demonstrate increased knowledge and awareness on Alzheimer's symptoms, risk factors, and most important, resources. Spanish en casa. Why do we need to continue educating and providing programs through a bicultural way? Because a record of 37.6 million individuals aged 5 years and older speak Spanish at home, according to an analysis of the 2011 American Community Survey by the Pew Research Center. So we continue speaking Spanish at home because we, in simple words, we push our children to also speak Spanish at home. One of our very important partners is the Hispanic media. And this is not just because we decided, but it's because the community decided. They trust a lot in the Hispanic media particularly TV and radio from Univision and Telemundo. Those are the main trusted Hispanic media to the community. And Lisa mentioned the lack of trust a couple of times, and this is exactly the Hispanic media is a perfect bridge to avoid lack of trust, and we're using them as a tool. So by 2034, 21 of the Spanish will continue to use Spanish at home. This is a study from Univision. Why, again, Hispanic media? The power of cultural communication. We cannot communicate without having hand with hand in a cultural way. And through the cultural way, we're going to go through history, tradition, values, family. I know it sounds really complicated, but again, we are dealing with a community with unfortunately, with the lowest factor of education in the United States. So what works more for the organization is three things. A key thing that we were discussing, we have a discussion every other year with the Hispanic media, and we have still the same three key points, which is a PSA, a flyer, or a press release, and integrate those three tools in the message that we want to send. So when we're talking about PSA, it's just a short awareness. When we're talking about a flyer, just communicate the community on regards if we have clinical trials to expose and explain, if we have memory test in Spanish, etc. And press release is always, the media is always looking for a family story. They really need a picture. So right now I would like to present a PSA that was working very, very well in actually New York, Chicago, and Los Angeles.
Hola, los estudios muestran que somos el grupo étnico de mayor riesgo en sufrir Alzheimer. Se calcula que para el año 2050 habrá 1.3 millones de latinos en Estados Unidos padeciéndolo. La Alianza Latina de Alzheimer, la Fundación Alzheimer de América, junto con el Consulado General de México, estarán ofreciendo exámenes totalmente gratis como parte del Día Nacional del Examen de la Memoria. No faltes del 17 al 20 de noviembre. Recordad, es importante.
Okay, so the message was actually for the PSA, just to, it's an invitation to the community to attend an event where we're going to have offering memory tests in Spanish. And the second sentence, or to support this message, is how important is to know more about memory loss in our community. Café con leche, this is just an example of a flyer when we involve the cultural and traditions again. So if it's just an example, in this flyer, we are announcing a conversation on regards Alzheimer and memory loss. And so for the Latino community, we tend to offer always some food and kind of music, and then a conversation in the community. This is what we call community charlas. So it's always to involve colorful illustrations. And this is a family story. This is from the LA Times and La Opinión, which is the most important newspaper in Los Angeles in Spanish, or for the Spanish community. So, and what I would like to highlight here is what they always looking for, which is a picture they always asking for. I want to see a Hispanic face with the problem. So it's actually what LA Times used it. In the other one, in La Opinión, the Spanish newspaper, we see two very good pictures. The second one, the small picture, is a health promoter from UCLA that was collaborating and working with us during a memory test event. And then we see a Latino lady that is taking the memory test. And the picture that is the larger picture on the same article, what we are seeing right now is a senior health fair that we do in every year in Los Angeles. This is a senior health fair. So we invite organizations that work with Latinos.
It seems that we lost Constantina for a minute, so why don't we go to her other video, which shows the story of a family caring for their mother.
Alzheimer's is a disease that creates a major impact on the family members that take care of the person affected with the disease. The probable reason why family members get sick is because of the constant worry and the need to take care of someone, their loved one, 24 hours a day. The support group is essential for the caregivers and family members of the Alzheimer's patient. It lowers their stress, and they go home with less stress, with more ideas and new friends. We start to have a better quality of life. That is the objective.
In the group, I learned where they lose their memory, but not their intelligence, and it's magnificent. I learned a very beautiful phrase: nothing lasts forever. So I live my life each day with joy if it's meant to be enjoyed, and I cry if I have to mourn. We are the ones that have to find the strength to keep moving forward.
Look at the little ones. And here's Mother with her cake. My mother takes medication, and what we do try to do is to encourage her. Look, it's you. Dementia can occur for many reasons, and I have a lot of fear, knowing that the same thing could happen to me, but I can't worry about that.
What do you want for your birthday?
I want everyone to give me anything or something.
To those people who begin to find out that their family member has Alzheimer's, I'd like to tell them it's a hard journey. It's not an easy journey, but everything is possible. First, you have to have faith that you can. Then seek help. You can find help anywhere. This works for anyone because you have to take care of yourself to have the strength to help your loved one.
I have learned a lot of lessons from my mother's illness. I have learned to be patient and enjoy each moment. I feel like that she is giving me the opportunity to give her a little of what she gave us, to fight for her, to see her happy, smiling, content, even though she is sick. Maria is still there. It is possible that she stopped being a mother or a grandmother, but Maria is still there.
I do believe we have Constantina back on the line, so we'll turn it back over to her.
Yes, thank you, sorry. Okay, well, I just want to close with some recommendations how to work with Hispanic media in a smaller scale. in both television, radio, talent. This is very important. Share your organization participants' client stories. Frequent radio interviews. Stop by the radio stations. If you can, 2 times a month will be great. Let the media know about your partnerships with other Latino organizations. The Hispanic media love to see how different organizations, the community are working together. And invite bicultural professionals to interviews. Don't just show yourself or the story. It's always a story, which is a family, and invite bicultural professionals. Conclusions: partnership between doctors, health promoters, and families. And my personal recommendation after all these years working in the community is do not assume anything. Thank you so much.
Thank you so much, Constantina and Lisa, for your presentations. We're going to move to questions and answers right now. As we are switching over our layout, I'll just remind everyone that the PowerPoint presentations will be sent in the next few days to all of you. And in addition, we will post the videos that were presented when we post our recording of the webinar on the Administration for Community Living website. And I will send that link when I send the PowerPoint presentations. So why don't we move to questions here. Lisa, this question is for you. It came during your presentation. The person was asking if someone has more physician visits, does it correlate with suboptimal care for patients with Alzheimer's disease or dementia? And it's also asking, or could it be hypervigilance about maintaining optimal care for the patient?
That's a very interesting question, and and I think it kind of depends. But I would say that we would like to see probably more access to care is usually better. So for physician visits, I mean, I think generally we would say, when someone has lots and lots of physician visits, and generally we would say that that person is pretty sick. But we wouldn't necessarily say that they shouldn't be going to their doctor. What we don't want to see is a lot of, inpatient stays and readmissions and that kind of thing. But, in terms of, what kinds of utilization we want to encourage, we want to encourage people to have a relationship with their doctor, to have a trusting, communicative relationship with their personal physician, whoever that is, whether it's a specialist, a memory specialist kind of person, a gerontologist or a neurologist or a PCP, but someone who, is really a partner in their care.
Great, thank you. Another question that came in while you were presenting, Lisa, someone was asking if they're asking about language barriers for the Asian Hispanic community. And I'm assuming that there's probably some research on that, but that might not be what your focus has been.
No, yeah, I mean, I know I haven't done a whole lot of looking at language as a driver, and I don't think there's a whole lot of literature specifically for Alzheimer's and dementia patients, but there certainly is a large amount of evidence out there about the issue in terms of, language and low English proficiency being a barrier to access in general in the U.S.
Okay, great. Let's see. Do you know of any studies that highlight lower incidence rates of Alzheimer's disease and related dementias due to preventive measures? For instance, do more minorities experience reduced risk if they bring their risk factors under control by a certain age?
So that's a very good question. It's not something I have seen in the literature. It's the kind of study that would be a dream study to do in terms of, taking a large cohort of a racially and ethnically diverse, large cohort and following them over time with, that kind of intervention applied to see if you can actually shift the burden of the disease a little. I'm not familiar with any studies that have been published on that scale, but it certainly is theoretically something that makes sense. There's pretty decent evidence, I think, that especially something like vascular dementia is heavily influenced by the burden of the diseases that are comorbid with that kind of cognitive impairment. So, heart disease and cerebrovascular and that sort of thing, and risk factors for those diseases. If you could address them, perhaps you could, reduce the prevalence or incidence of vascular dementia. I'm not aware of any good evidence that shows that Alzheimer's itself prevalence could be reduced just strictly through reducing those risk factors. But I think that the state of the science is still uncertain in that area.
Okay, great. Constantina talked a little bit about some efforts that she's undergone to kind of educate about Alzheimer's disease and dementia in the Latino population, but are there other efforts that either of you can speak to nationally or on sort of a regional level to bridge the gap between the disparities? And how may people on a local level take advantage of any of these efforts?
Yes, thank you, Sari. Yeah, but we are working very hard right now on let the community know what is a clinical trial, and before know which are the clinical trials they are offering to the community. So because like we hear a lot of the lack of the participants, Latinos participants in clinical trials. So we're working very hard on that, and we look to partnership with more and more. Right now, again, we're working in Maryland, specific in Baltimore and around Baltimore, in the whole state of Illinois, and New York and California, and we start in Texas. But we focus on that. We are, our partner is always the Hispanic media, also NCLR, the Council of La Raza, National Council of La Raza, and other institutions. We have Sinai Hospital and New York and Chicago. We have other hospital institutions and clinic. We also work with departments on aging. But we are focused right now through the health promoters on let the community know about what is and how can they participate in a clinical trial.
Great, thank you. Lisa, anything to add on that about efforts that you know of?
Nothing to add, no. Although it's very encouraging to hear that that effort is ongoing.
Great, thank you. Another question about if similar disparities that affect African American, Hispanic, and Asian American communities also affect the Native American communities, and is there any literature specific to the Native American population and Alzheimer's disease that you know of?
Yes, this is Lisa. I unfortunately was not able to find any literature on Native Americans and disparities related to Alzheimer's and dementia. We certainly know that there are health disparities among the Native American population, serious disparities. I'm sure that if we had a good source of data that had a large enough sample, we could certainly demonstrate the same sorts of disparities that we see in other diseases, in a dementia population. I think the disease is probably quite underdiagnosed, and that that really is a barrier to conducting, good population-level research, because the population itself is so small anyway that when you get into something where you're looking at, 10% of 1%, it's a very hard population to study. This is one of the challenges that continues in this area, is that we deal with very small populations, and so it's hard to get good evidence sometimes. But it is a gap.
Thank you. We have another question about, do either of you know of any good educational programs or how one might educate healthcare providers who may not be as culturally competent in working with people people who are in minority groups? Are there any organizations that you know of that are doing such trainings?
Hi, this is Constantina. In the Latino Alzheimer's Alliance, this is another part of our mission, and every year we educate. For example, we have Loyola School, for medical school. 2 times a year, we provide them a training on ethnic and bicultural. And we also educate not only medical staff from different hospitals, but also educate their health promoters. There is many hospitals across the country that they already have their health promoters program or group. And sometimes those health promoters are already training in cardiovascular disease, but not in Alzheimer or not in dementia. So it's where we go and train them. Actually, we just were working with 2 groups of health promoters in Maryland last fall, including a group of health promoters from Johns Hopkins Hospital.
Great, thank you.
I would just add that there are definitely programs out there on cultural competency. We have some, I know that we talked about some of those programs in the review that is provided at the end of my presentation. There are also some, it's a continuing area of development of inquiry. I was just looking at a paper that is talking about a new cultural competency instrument. So there are some validated instruments that have been developed, and so it's definitely an area of a lot of activity, and I think we'll continue to see people developing good assessment instruments and measures for this kind of thing, and programs for improving cultural competence.
Well, great. Thank you so much, Lisa and Constantina. We have reached the end of our time together. We were able to answer most of the questions that came through. If one of your questions did not get answered and you would like me to forward it to one of the presenters, you can find my contact information. I'm Sari Schumann in the closing notes on your screen. You can contact me via email. I'll be happy to pass on your question. And I would like to again thank Constantina and Lisa for wonderful presentations and a great session. As I mentioned, I will send out the PowerPoint presentations in the next few days. We also have a recording of the presentation that will be available on the Administration for Community Living website. I will send you all that link as well. So thank you, everyone, and have a lovely afternoon.